Today on the podcast, I have with me Aaron from Pragmatic Paramedics.
As far as like the whole degree versus certification requirements for EMS, like I know it's that hot topic in most of the crowds that I follow, especially with y'all and on the Pragmatic podcast. The episodes that like I want to highlight are obviously the ones with Max Dodge. And like I said, like the hot topic of the idea of a degree versus recertification. And I'm approaching this more in the mindset of like a devil's advocate for a just recertification versus degree, because I'm not 100% sold either way. um I feel like I'm not saying it's not going to affect me per se, because I'm probably going to fade out of EMS before any big changes happen, and slash or I mean, I'm recerting in March and I don't want to go back for a degree. But now I want to play both sides just to kind of give light on one way or another. But also, I mean, as I'm weighing on like the recertification side, if having a degree weeds out the providers that are pushed out like a mill factory out of these programs, and the bad apples that are produced that can't write a decent report and don't care and slash or don't understand the basic pathophysiology of what we carry and why it works and why we change our approach to things because this is how we've always done it. Like if that takes care of that, sign me up, coach. um
Yeah, I don't know if it'll do that. I don't
Sadly.
I don't know if the initial and sometimes I wish I had Max's brain. I don't know. He's just really smart and like the way that he thinks about these things is just different than how I think about them. I enjoy talking to him because I learn a lot from him, and he would give you some really like great example and answer. What I would say is that I think degrees in the beginning stages are going to be beneficial, but only beneficial to the people who take the time to do them, right? Because they're not going to be mandated. It's not going to be an obligatory thing. Like you just can't say like tomorrow morning you have to have a degree to be a medic now. So it'll start out probably as something where if and when it does, I'm going to stay positive and say that it should happen sometime within the next maybe 10 years, right? I don't know. But you're going to get people. I'm going to just use me as an example. You're going to get people like me who do it, right? Because they're going to be the ones who want the degree. So it's really just going to be the same people who would have done it anyway. I don't
Yeah.
know if that roots out the shit, the trash. I don't think it will, because as long as you have the ability to not have to get a degree, then those people will remain within EMS. Um, that being said, degrees degrees aren't a silver bullet, but they do fix certain things. And I think if you have providers within the same department, and let's just say 50% of them have the bachelor's degree or whatever degree it is, associate's degree, and 50% don't. And we're just using this as a devil's advocate, 50% who don't are the shitty medics, and the 50% who do are the good medics. I think you are setting the bar higher, right? And by setting the bar higher, I think that either weeds out people or forces people to step their game up, right? So you don't want to be the worst paramedic in your department, do you? No.
No.
You don't want to be the guy who sucks at every fucking thing. You kind of want to be capable of like saving a life every once in a while. At least being able to transport them and get them there in a better condition, maybe than you left them, or at least a similar condition to where you picked them up. Um, so when you raise the bar, you essentially are going to start weeding people out or changing their mindset. But I don't think that's a fair analogy, because I think you don't necessarily need an education to raise the bar. I think
Fair.
I think you can raise the bar without having a degree, but I do think having a degree inherently raises the bar. Does that make sense?
Right. So, like, one big thing I have about it is that, like, yes, raising the bar, you get out what you put in, that kind of thing.
Mhm.
But the idea that, like, do you really, is it not necessarily required, but is it necessary to have a degree versus like a recertification for some of the patients we run on? So the run of the mill, like, I would say that 85% of calls, like headaches, flu-like symptoms, broken ankles. One we had of, I took one Adderall 12 something hours ago and went to work, then smoked a blunt, and now I feel nauseous. Like, I don't, you don't need a degree for
Other way
that.
around. It's always the other way around. Blunt,
Uh,
then Adderall.
right. She was a special case. But
No, I yeah.
so
You so what you're asking is, do we need for our everyday mundane runs? Do our paramedics, do our providers need advanced education or advanced, not advanced degrees, but a degree? No, because for lack of better words, the majority of those patients didn't even need to go to the hospital, right? Let alone the hospital. They probably didn't even need to go to their provider. They probably could have grabbed an ibuprofen out of the fucking cabinet and dropped their temp and drank some water, and they would feel a little bit better the next day. But they didn't, and a lot of that stems from health literacy, right? People just have very low health literacy scores, generally speaking.
mhm,
It's hard to say about EMS, but the people that you run on probably have just they're in the shit, or the emergency to them is so great that they didn't know how to navigate that, which goes right back to health literacy, right? They don't know how to navigate the healthcare system, which brings me to why how this would work in my mind. So, first, the way that I see medicine, EMS is a part of the industry, as you probably as everybody already knows. It's a part of the healthcare industry, but it could be a comprehensive part of the healthcare industry. And what I mean by that is, so yes, let's say you show up to the toothache, or let's say you show up to the headache, or let's say you show up to the, I don't like headache because headache can be very,
right.
you could have
Yeah.
a real headache. But we'll just say that it's something very simple. Let's say sour stomach, GERD. You show up and they're, oh my God, oh, I'm having a heart attack. And you do a 12 lead, and maybe you have, and you don't see anything on the 12 lead. They have no history. They're like 25 years old, and blah, 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 or whatever. 30, we'll just say 35 years old. It's a woman, and she's been complaining about it, but she has a history of it. So that's the point, right? So like you don't have to have a degree to do this, but when you make it comprehensive, this is where you can do education, right? You can explain to this person. You also have buy-in from the physicians at the hospital or whoever your direction is to make decisions on behalf of them that are best for the patient. And so you can determine right here at the triage, this patient's not going to the hospital. They don't need to go to the hospital. What they need is omeprazole and a change in diet.
Hmm.
So you can kind of help them through that. And I'm not saying that you just give them an omeprazole and leave. You go through, you do your vitals, you do your care, you do education, you listen. If you find something like wheezing, give them a treatment. You get them back, and then you follow up with them. And and that's the key to the care. And I think that's where you start seeing the need for degrees, is because we have to have a better understanding of how all of this works. Everything, the whole healthcare system, how diets work, how medications work, how pharmacies work. I mean, it's not so simple as to, you tell somebody, why didn't you get your fucking omeprazole? It's easy for you to think that, right? Like it's very easy for me to go, all you needed was the damn omeprazole, you dummy. But they don't know that. They may think that they have to have a prescription for it. And I've encountered that, right? There are people who are like, no, my doctor gives me Prilosec or Protonics. And It's prescribed. Well, yeah, that's prescribed, but you could also go into the pharmacy and pick it up.
Yeah.
When's the last time you did a treatment? Well, I ran out of my albuterol. You ran out of your albuterol. Okay. Well, let's work on that. We can do that with you. And you can, in that, just support, right? Because that, you have a physician buy-in, you have hospital buy-in, you have PCP buy-in, and you have community buy-in. I just think that it requires more education. I could be very wrong, but there's a lot about college where I learned about society, like more about society and diversity and socioeconomics, which is just a big word, right? But eh, I'm not saying that most medics don't know what that means, but let's be honest. It's not a word that every single medic is going to know. And do they even give a fuck about it? And so if we care about those things, economics, socioeconomics, food deserts, can there's so many things that keep people going back to the hospital that we as street providers can simply just drive up to the front of their house, get out, go through this treatment plan, what's going on with them, and get them to a place where they no longer have to utilize EMS to go to the ED. And by doing so, we've reduced not only like just the burden on the emergency department, but there's no length of stay involved in that. There's nothing, they're not even being transported. So all the reimbursement goes directly to EMS. But
So
again, I don't know if that means that needs a degree, but we do know that degrees help with critical thinking, as Max so eloquently stated during our one or two podcasts with him. I can't
okay,
remember which one he talked about it, but
it's one of them. So like
yeah.
in that line of thinking with the degree, where would be the line drawn between like you go get your degree for that critical clinical judgment aspect and being backed by a PCP and like all of that good stuff versus just extra training to be like a community paramedic and work in community paramedicine?
Yeah, no, I think you could. I guess the point is why do it all without getting the degree?
Fair.
So yes, you can 100% get all of that training without having to get a degree. But the thing about the degree is there are other things that come along with it. So I use this frequently when I argue in favor of degrees, is English comp, right? Just English 102 is sorely lacking in EMS by reading charts. Um, the argument that people usually give me back is, well, have you ever read a nurse's chart? It's not much better. I don't know. I've never compared the two charts to say, but in my personal experience, and I'm not knocking EMTs here, but I've read some fucking EMT charts. And again, I'm going to use the word tar, and tell you that that's what I was very confused by their chart. Like it didn't even make sense to me. There was, I could read the words were in there, but they were so poorly uh composed in the stringing of words just made no sense. There were no punctuation. They were misspelling words that shouldn't be misspelled, or they were using acronyms that are not legitimate acronyms. Um, I've I've never seen. I mean, I'm sure there are bad nurse charts, but I've never seen a nurse chart to where I couldn't. It was illegible. Like I couldn't read it.
I will say on
So
the pro side of that, I do agree. So I don't use my English degree anymore, obviously, but when I write a report, I mean it's that basic concept of like how it visually looks and how are you painting the picture. And one thing that I tell people who they come at me and they're like, your reports are so long. Yeah, because I'm dumb and I'm going to forget this if it comes up in court, which it won't come up tomorrow. It'll come up in the next 5, 7 years. So yeah, I want it to look nice, to look like I know what I'm talking about. And also, I want it to be readable, or not legible because I'm not
Yeah.
handwriting it, thank God. But I want it, it's just that it's also that aspect of like kind of on the same mindset of like being a decent, competent provider who can,
Well,
you,
yes.
you can tuck your shirt in all day long, but if your chart looks like trash, like what good are you actually doing? Because that's also what insurance looks at. That's also what, I mean, I hate to bring it down to money, but I
I
mean,
mean, yep. I mean, that's how we get reimbursed, right? So
yeah,
we're reimbursed based on certain. Look, there are people who are way more. They understand that whole shit better than me by a million years, but you're probably not going to get reimbursed if everything you said doesn't make any sense.
yeah.
If the person reading is like, what? One, CQI is probably going to kick it back to you and be like, look, I don't even know what the fuck this means. But if it makes it past CQI, you're working a large department where they just don't have the ability to read through all of them, and somehow, it gets to the med billing people and they read it and they're like, yeah, you may not notice it, but if you do 500 runs a year and all your runs get kicked back or none of your runs, you're costing money to the agency. I mean, that's a cost on the department because you can't fucking spell. Uh, it's not a big cost, but over time, if I think in one year I did a number on how many transports I did, and this is back in 2013. And in my first year, I did like 2,000 runs or some. It was some number. It was a decent amount of runs. Imagine if every single one of those runs got kicked back. How much work does that take CQI? How much work does that take the insurance? How long does it take to get reimbursed for that? Because you can't do the basic, you can't do basic um you can't do basic writing. And it's the same with math, and it's the same with science. Look at math. Like people are like, oh, I don't need math. Shit. Med math is a thing. I mean, I know that a
Dude.
lot of the protocols do a lot for us. You wait till we get a shortage on something, and
Yeah.
then you got to start drawing it up yourself and trying to figure out, what the calculations are. And that is life or death in some instances. Because if you fuck up a dosage, sorry for my language, but if you fuck up a dosage and you give whatever dose to that person and it kills them, we're on to Vought. I mean, I know she gave Vec, but the point is and it wasn't a math calculation, but you will be the next person to be on the news because you killed a patient by doing something stupid. Um, so I think that degrees in some ways benefit the individual. And I was going to mention this to you, and I may be getting off track here, but I don't like thinking about degrees in for the industry. My thought is they will benefit the industry. But what I care more about, what I am trying to push for my you know, this little corner of the world is degrees for people, for the individual, because the individual is who matters. And if I can make you, or if you can make you a more well-rounded individual, then you're going to be a more well-rounded individual who does better work for the industry. And if you choose to not be in this industry, for 20 years or 30 years, you still have a degree and you can still utilize that degree. It doesn't have to be, necessarily EMS. There's a lot of places who just because you have a degree will hire you just because of the degree, because they know that you're willing to put in work and finish the job. It's kind of like Eagle Scouts, right? Like people are like, "Oh, why do you even bother getting it?" Well, because it shows that even though during, my teen years and all the shit that was going on, I still completed something that's pretty. fucking tedious. And by finishing that, it doesn't make you a better person, like in the world. Like people are like, they're not bowing to you, but it does make you a more well-rounded individual. You know things. You have you have thoughts that you wouldn't have thought before. Like I took a course, a medical humanities course. It was a pretty cool course. It turned out to be all reading and all writing, which that I didn't want to do, but whatever. I learned a ton from it. And I was able to take what I learned in that class and directly apply it to patient care. Directly apply it. Because I learned that there's more to medicine than just medications and interventions. There's communication, there's understanding culture, there's understanding people, um, there's this ability to, I'm not saying this course taught me that, but there are things that you start, because when you read or you look at art or you write, you start to look at things more close, or you expand this picture out and you start looking at all of the things in the house instead of just the patient. Or like most people walk, I'm not saying most people, but people walk in, they start looking at the patient, they start going, doing this, that, and the other, and they haven't looked at the whole surrounding. And by taking in the whole surrounding, you are able to more effectively treat that patient and have potentially a better outcome long term rather than pick them up because their blood sugar was low and transport them to the hospital. You don't even know what's going on in the house. You just decided, and you are going to come back to that house because no one's doing anything about the situation at home. We're only reacting to the initial low blood sugar. You pick them up, take them to the hospital, drop them off, go to White Castle, get a sandwich, go back to the crew room, right? Like it's really poetic because that's what we do. We go, we like, "Meow, meow," you jump out, you walk in, you're like, shit, it's low blood sugar, come on. But from my personal experience, from the experience I've had with all the people who I've worked at, degrees and not degrees, degrees have a, in my opinion, have a better people with degrees, one, tend to stick around longer,
Because there's
right?
more
So you won't
buy-in.
have this. Yeah, because they've decided that's what they want to do. So they're sticking around. And no offense to anybody who leaves the industry. Could you imagine every 3 years you have this huge turnover of where you had a medic who's just now I don't know what the year is where they consider you like pretty. I don't think it's like year 3 or 4 or something like that where they consider you, and obviously a lot of it has to do with where you work and your volume and how often, but there's some number like every year 4 or year 3, you're just starting to really get to the point where you're comfortable with providing care. And I bet our attrition rate is much sooner than that.
Oh, absolutely.
So yeah, like
Burnout
you
is
just
about 2 years in.
right. Yeah, I mean it's pretty quick. Well, I mean the department that I started here in Indianapolis at, I don't know anybody. I don't know a single I mean, I probably know people who work there still, but you know what I mean. Out of 200 some souls, I could I run past. I used to be able to drive past an ambulance and I could tell you who that was in the ambulance.
Mhm.
Nowadays, I live in the city that I work, so I run into the ambulances a lot, and turnover rate is so high. And maybe it's degrees, and maybe it's not degrees, but people with degrees tend to have they stick around longer. Um, they also at the end of at the end of all of the stuff EMS, they just tend to have better overall quality of life. They have higher paying. They have they're less likely to be unemployed. They live longer. I think there's like some I don't want to cite it, but there is like they have longer. They live longer. They choose um I don't want to say that because I'll be wrong. But the point is, QOL is increased. I did a whole research paper on it once, a long time ago, and that was my conclusion. Was degrees. I've been advocating for degrees for like 10 years, 8 years, 8 years. It just I somehow stumbled on it and found it, and I think that I don't want to put anybody into a financial situation where they have to pay for it and now they're paying it back. But an EMS degree that's specifically focused on EMS, right? Not a degree like, no offense, English, because English is a great degree for English. Like if you're going to be in English, like you and I think Ginger are the only two people besides my mom who has a degree in English. So there's three people I know, and my mom is a writer. But outside of that, what does an EMS, what does English bring in? What does an English degree do for you as a paramedic? It makes you a better writer, right? That's
That's
about all.
about
You probably,
it.
you probably would have been you probably still would have been a good writer if you chose English. But I guess what I'm saying is we in EMS professionals need a degree that's very EMS related.
Right.
So it should involve a lot of clinical stuff, similar to how we do our associates program. Um, but there's just not a lot of them. I think the number David Pfeiffer gave me one time was 25 EMS bachelor's degree programs in the United States. That's it. 25. I mean, if you think about it, there's probably 25 colleges in Indiana alone or
Mhm.
more. And yet there's only 25 places to choose from. So the big push that I hear from people who are talking about this is that we don't have access to degrees. And that's what they're wanting. They're not saying that anybody has to have a degree right now, right? Like we're not pushing for medics to have degrees tomorrow. We're pushing for opening more doors for paramedics to get degrees in this field if they want them. So going from 25 bachelor's programs in the United States to 100 or 200, so that people in rural America or people who want to get a degree, like a legitimate degree in EMS, a bachelor's degree, can get one. Because right now, the closest paramedic degree to me is Eastern Kentucky University, and that's probably 6 hours from my house.
Mm-mm.
It's just not doable. I mean, I could do
Mm.
it online, but I mean, don't you want to go to school that's around the corner? Like, where you want to be able to go like 20 minutes, sit in the classroom, kind of meet the people, meet your professors. I don't want to do an online school for everything. Anyway,
Well,
where we at?
as far as like, here's my thing on the degree. Like, yes, it makes you a more well-rounded individual, and like, I, for me, like, I had to have a certain amount of like arts, and so taking my ceramics 101 class didn't really help. But besides that, um, do you stop at like the college degree? Because let's be honest, it doesn't hold as much weight as your master's degree nowadays. And then taking it into the healthcare aspect, some RNs don't have a BSN. And then, like, how I look at it whole picture, there are things we just can't do on scene or in the back of the ambulance. And there are things we aren't going to be capable of doing in this field versus what can and should be done in the ER. And that's like, I'm not saying our only job, because I fully push towards the community paramedicine wholeheartedly. That meme of like, take my money, like, absolutely. But I mean, as 911 medic responders, like, at least now things could change, but our job is to stabilize and transport to the ER. And we can always train our community paramedics and like our 911 medics specifically to do like your fast exam, your POCUS, ultrasound, all that stuff. But at the same
So
time, like, you can push that
if
training
you,
for one medic versus if you have the one with a degree that doesn't have the time and training and doesn't really dedicate towards it. I mean, we're still going to be limited in the back of the truck.
you mean what we can do?
Yeah.
So give me an example if you
Like,
have one.
I mean, granted, it widely depends on your agency, but like, most agencies don't let you do a chest tube in the back unless you're a flight medic for whatever reason.
Do you
Uh,
think that putting in a chest tube? So let me clarify. Are you saying that we don't need to be doing that, or
no,
we
I'm
could
saying
be?
that like having a degree or not would just be a matter of training, and not even just chest tubes, but like running labs,
You don't think
doing
it needs a degree to do those things, right?
yeah.
No, I agree with you. It doesn't. No, I
So
wouldn't argue with it. I don't think that, I don't think skills, so I don't think degrees in training, so education and training are the same animal. So what we're talking about skill wise is not something that I would necessarily add to the education in EMS, right? So do you really need to go to college to learn how to intubate? Probably not. But you do need to go to college to learn how to intubate and when to intubate. Not college necessarily, but you need to go to school to learn why you're intubating, the pathophysiology behind it. Those are the things that you do. The skill itself, no. I mean, we can teach anybody to do a skill. We don't even need a fucking ambulance. We could just remote Uber people, the majority of our patients. But I think if you and if you take a lot of the if you remove a lot of the congestion of what we do currently. So we're transporting, mundane toe stubs, to the ED, and we're just being burnt out by doing all this. But if you have a system in place to where you're reducing those frequent utilizers, super users, or whatever they want to call them, from the system, to a point, you now start to be able to focus more on the actual emergency aspect of EMS. And so you can actually get in to providing more focused interventions. So things like chest tubes and those sorts of things. And I think, I don't know, but I think if this whole seat at the table thing where we're talking on the other podcast or with the pragmatics with Max, seat at the table allows for physicians to be more confident in you as the provider. And so they're going to be more likely to be liberal with their protocols. And so things that we're not doing now, because let's be honest, the reason why that a lot of our shit is handcuffed is because we fuck things up. We kill people. And no doctor, I can't imagine, is like, I don't mind my license being on the line. I really don't care. I'm gonna go ahead and let everybody do whatever they want because, at the end of the day, I'm getting paid. Like, no, he's gonna get in trouble or she's gonna get in trouble too. And so if you have buy-in from physicians, if you have the trust and the confidence and the respect from these people who are we're helping write protocols or they're writing the protocols for us, they're going to be more likely to say, you know what, we're more confident in your skill set because you can talk like we do, like the whole emergency, right? Like firemen who talk like doctors. I disagree. I don't think they talk like doctors. Uh, but I think we could talk like doctors. We just have to have more education to do so. We just don't know all the same things. Um, and I'm sure that this will catch a lot of flack. But Max said that, I argued that the whole well monkey can intubate. He was like, sure, it can. But have you ever seen I don't know if he said it like this, but he basically said, but they don't know when, they don't know why, they don't know how, right? They know how, but they don't know all of the things. So it's different. And what happens and that's a mannequin head. So what happens with it when the anatomy gets, you know, covered up with saliva and mucus and blood, or it's
burns.
not the anatomy that you're expecting? Now things have changed. And so the medic who's really good at the skill because that's what he does may not be able to think on his toes because it's changed. Something's changed to the point where now he's uncomfortable or she's uncomfortable. I just think that a lot of critical thinking, from in my experience, was learned not just through life experiences, but from being in school and not medic school. Medic school, I did simultaneously as with an associate's, but I learned the majority of the things that I learned about the world around me from the other courses, from all those fluff courses. Even ceramics, you use ceramics as a, have you ever seen somebody that sucks at ceramics?
Yes, I did.
So, but what does it take? It takes perseverance. It takes understanding that failing is a part of the process, and it takes a fucking great attention to detail to be a good pottery maker. Like you really have to hone those skills. And I think that's what it teaches you is, you know, you you become better at one thing because you practice and you practice and it's like there's this weightlifting analogy and a lot of it is about building muscle and building repetition, but the whole no pain no gain, that you've heard that phrase before. People lift weights. This is just my example and somebody, I'm sure I'm going to get good, yeah, but people who are willing to go to a point where they no longer feel comfortable going are probably going to be more likely to push themselves in those critical situations. Have you ever been under a bar on a squat to where you don't think you're going to be able to get it?
Yeah.
And you're sitting under the bar and you're scared because you don't want to get crushed by the bar. I don't have safety racks on me, so it can be scary. But when I push through and I get it, then I know I can do it. So I've learned that I am actually capable of doing that, which I didn't know before. And I taught myself something. And so I do the same thing at the hospital when I start IVs. It's a terrible example, but the reason that I find that I'm good at starting difficult IVs is especially under ultrasound is because I am unwilling to quit. And I'm not going to sit there and dig and poke and hurt, but I spend probably 25 minutes just mapping their arm with the ultrasound, talking to them, making them feel comfortable. Then I put the tourniquet on, not the tourniquet, but the band. I put the band on, and
Yeah.
it allows for all this thing. And that is all stuff that I've had to learn through process and failure, process and failure, and process and failure. And as long as I know that if I can fail on this squat rack and still get back up, I can do the same thing in this. But I know that's not education, it's not a degree, but it does have some tie-in, right? Because when you do things like that art class that I took, it taught me to look at things from a different perspective that I never would have looked at before. And I was already a paramedic at that time. I had already been practicing, but I learned so much from just that one course that it made me think, what did I learn from all the other courses that I took?
I feel like kind of at least my fear on that aspect of like you get a, getting the degree, which I mean, I'm here for it to better yourself and stuff like that. But two folds on this. One, back to the idea of like you get what you put in. I know people who somehow cheated through paramedic school. So you can cheat through a degree and slash
Sure.
or like you take your classes just because you have to take them. I took some pretty good English classes that I mean could have helped me in my degree. Because I almost had like an entire minor in education. So like there were some education classes that like would have been awesome if I got something from it looking back, but I just had to take it. So I didn't give a rip. And then at the same time, like, um, just like, I mean, you have the calls and stuff like that, like the cost of it, but also like if we're going to ask these medics with degrees to come and work on the truck and stuff like that, is there going to be like a balanced pay in that? Because I mean, we're already hurting for staffing and medics in general and stuff like that. But your medics with degrees, are you going to pay them more? Because I mean, how our system runs is that you have the billing per mile. Like, absolutely, that's, you have your starting billing, but we, like, on our events log of like what we did, this, that, and the other, blah, 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 we bill per that. But also, if I put in my report that I, put my patient on an end-tidal nasal cannula, even though that's not on the events log, that gets billed. So as far as like, you get whatever result and success you put into it, it could also fall under however much training you get. Because in paramedic school, for me, like, we had to log in so many intubations during our lab week or live week, whatever we called it, to get like that skilled checklist. But I mean, me and some other people, even during lunch, we skipped lunch that day because we were just like throwing tubes down and like looking up videos of like difficult airways. The program I went through was like, I think you had to do like one thing to get it technically associate degree certified, something like that. So like, even though I don't have the associate degree, as much training as I put into it, I feel like I'm not saying I could, but I feel like I could go toe to toe. So I
But you
don't
already
know.
have a degree, right?
Yeah,
Yeah, see, you already have a degree. It's hard when you already have the degree because you're correct. You have all of I would imagine you have all of those traits already, the ones that you're going toe to toe with. You just aren't seeing it that way because, or maybe you are seeing it that way, but I guess you have both a paramedic certification and a degree. Now, is that degree comparable to an EMS related degree? Probably not, no, but you learned a lot from that degree that you are applying either directly or indirectly right now. Even right now, your ability to communicate all of those things are because not because are as a result of something that you learned somewhere along the way. And I would argue that you probably learned a lot of that during your English degree, and maybe you were able to, maybe people don't look at it that way, but the degree itself is a part of, the degree that you have is the thing. So I would like to hear from someone who doesn't have a degree that feels like they could go toe to toe. You know what I mean?
fair. Yeah.
I'd like to see what they're. I mean, I know what they're saying because there's a lot of people that fucking hate the fact that we talk about degrees in EMS. So when it comes to the money, I mean, I think we know. I think we can look at pretty much any study that's out there that degrees, generally speaking, are result in higher pay, bachelor's degrees, and maybe even associate. I think associate degrees too, result in higher pay compared with a high school degree. But I don't think that should be our goal. And it's going to be what people ask the most, right? Like, do I get paid more? Right. You should, but it shouldn't be what we're looking for. Our aim should be to be improving quality of care, changing the way that we reimburse, so treating in place, and not billing just for transportation. And then I think when you start doing all the things that we spoke about earlier, you're going to start seeing higher reimbursement rates and potentially more money come from the hospitals because they're going to say, these guys are keeping our floors relatively clear from, so we can take care of the patients we have to. And you probably will get um, money. You know what I mean? You probably get paid more from that. Um, but it's a good question. I don't know. I don't know how long it takes to see the fruits of our labor. I don't. I don't know. I also don't. I also don't know if pay. It's hard. I'm gonna have to think about that one. Can I think about it and then get back?
Yeah,
Sorry.
no, you're good.
I mean, I wrote about it a little bit here, but I just don't want pay to be the focus. Like I didn't go to college to get paid. You know what I mean? Like I didn't get my degree necessarily to get a. I knew going into college that I wasn't going to be a millionaire. Like I probably could have gone to Yale. I didn't say I probably. My point is I could have gone to Yale and got a degree if I was smart enough, and I would more likely be making six figures, right? Because the Yale is really the thing that people are looking at. I wanted to be good at EMS, so I went into school for EMS, never thinking that I would get paid $10 an hour at my first job. You know, it never struck me as that what I was getting. Pay was not the very first thing that I thought about. The very first thing that I thought about was doing something for the community, as cliche as that sounds. That was my intent. I went from the military directly to EMS, and I just wanted to continue being able to serve in some capacity. Um, Never really knowing that pay was so awful within EMS. Um, I do a lot better now, um, but that's because I work for a hospital, and the hospital really just pays people better. So yeah,
Um, one last little aspect I want to highlight on, because like you brought it up, the whole idea of like sitting at the table with higher level healthcare providers. I personally, this may just be me, I don't agree that having a degree would change any of that. And I have a small little tangent, so buckle up.
the buckle.
Um, like that idea of sitting at the table with doctors and stuff doesn't, I would say, equate to EMS because of the difference of education and training. So like having a conversation with the doctor and saying that like, hey, what I have is, I'm not saying as good as, but like we can hold like the same level of education because it's an entirely different field. So a doctor in the ER may not even have ever looked inside of an ambulance, but can critique the paramedic. And while, all the while the doctor has no clue what our scope of practice is. And on the flip side, some of the providers like RNs, RTs, and especially like medical school in general, there's specific areas of studying and hours required and things like that. So things like that. But like if we increase the number of hours required and or courses taken, are we still going to earn our respect by having a degree and tagging that into the end of our email? Because like we talked about, like this isn't going to change those providers who basically give up and look sloppy and burned out, which happens with long hours and little pay and stuff like that. So on the same idea, at the same time, like on an airplane, when it's asked, like, is there a doctor on board? You could have a doctor of philosophy stand up, or art, because they have that education, or the podiatrist or an ophthalmologist. No offense on those. So, working in EMS is a different animal compared to an ER level of education that's required and isn't necessarily the same as ours, even with just a bachelor's degree. But arguing that we deserve the same respect that RNs have, we don't, I mean, I hate to say it, we don't have to wait for basic orders to push medication because we already have a medical director, an MD, who has wrote an order that using our clinical judgment, if we see this push XYZ because of our clinical competency. And would a degree change that? Possibly, but we have the protocols. We have, I mean, I'm not saying National Registry is the end all be all, but like if you can pass that, there's at least some part of you that can see, hopefully, that if you, even not just like if you see chest pain, do this, but if you see chest pain, that doesn't mean that they need aspirin or nitro. You have your cookie cutter medics who do that, but would a degree necessarily change like that end all be all. You fall into the same pattern, that kind of thing. I don't know if that would change. I don't know if necessarily having that degree changes that.
So first, let me just start from the type of degree I think that was being referenced.
Right.
So I'm pretty sure what Max was trying to say when he mentioned that, 'cause that's his stick, right? That's his word, that's his phrase. I did not come up with that. I do. It's been hard for me to envision, right? Every time I envision it, I just imagine like the circular table
Right. I
where
think of
all
Knights
the
at the
people
Round
are sitting
Table,
there, and like
the
I'm sitting
Last
there
Supper.
with all these doctors in lab coats, and I'm trying to explain something. Um, I think it's both, right? I think it's a metaphor, but I think what he was referencing it was we don't have people with advanced degrees, masters and PhDs. There's no master's degree for EMS, and there's no PhD for EMS. And if there is, there's a very select few people who have them, and even the ones who are paramedics that do have PhDs, their PhDs, and this is max, right? I'm paraphrasing. Even those people who do have PhDs, their PhD is not an EMS PhD. They have a PhD in public health. They have a PhD in, um, you know, education. They're not. They are not EMTs or paramedics with a PhD in paramedicine. Does that make sense?
Yeah.
So I think what Max wanted to say, he did say it. Some of the stuff is he's way smarter than me. But the way what he's referring to is not a bachelor's level degree, not a clinician level. Rather, he's talking about people with master's level degrees and PhDs sitting at the same table as these doctors and nursing, nurse practitioners and DNPs and the whatever they call the chief nursing officer of the hospitals, where we're making changes or we're talking about or discussing change with those very individuals that directly affect us as providers. Because right now, most changes that occur in EMS don't have paramedic buy-in. There's no medic necessarily sitting at the table having a conversation with these people. They're just doing it for us, right? So physicians essentially make all the decisions for us. And we don't have the ability to say, oh, we can, because you said it, right? Not all docs have seen the back of an ambulance. And so you've got to have somebody there that can say, boom, yeah, that's a really great idea, but it isn't going to work. Because I can tell you from experience that there's just no way that we can apply that here. So putting that into our protocols is absurd. We need to think of something that's a little bit more fluid or easier for use. Like how many times have you this is again a bad example, but how many times have you been told we're getting a new monitor or we're getting a new type of equipment, we want you to test it out, and you test it out and you go tell them, and everybody fucking hates it, and then you get it like 6 months later and you're like, wait, no, I didn't want this. Nobody said
Yeah.
this. It's because there's nobody really advocating for us, because nobody's sitting at that table. Sure, there are, you know, leadership paramedics who sit as chiefs, but really, those guys are not, they're not really sitting at a table having an educated conversation. They're just kind of relaying information. Max used economics as his one of the arguments for being able to sit at a table. Like if you don't understand economics and you're sitting at a table with these change makers and policy makers and you don't understand it, how are you going to be able to communicate or add to the conversation. You can't even, if you don't even know the basic concept of economics, you can't add anything. So you're really just sitting at a table and being completely unproductive. You have to have an understanding of all of the things that you learn by going through a bachelor's program, a master's program, or even a doctoral program. Um, I I am not saying that everybody needs to be have a. I don't want if so if we become APP, if there is this advanced paramedic that's a master's level, I do not want it to be like the NPs, like nurse practitioners, right? Because every fucking nurse I know is getting their NP, and I
Yeah.
just doesn't make any sense. Like, should you be striving to be a better provider? Sure. But does everybody need to have a master's degree in EMS, or does everybody need to have a doctoral, degree? No, but there have to be more people to be able to be sitting at that table we're talking about, and being able to contribute um in a way that's productive, so that when change is needed, or when things are changing, we have people who can advocate on our behalf in that way. Hope that helps.
Yeah. Yeah. And
But do I think degrees for the clinician are going to change things? I do. I think that they're going to be all of the things that I kind of said in the beginning. I think what it's going to do is it's going to make EMS mobile integrated health, where we are communicating with on a routine basis, primary care, physical therapy, pharmacy, dietitian, dietary, respiratory therapy. And we're going to be able to take all of those things and utilize them in the field, so that our patients are not going to be repeat customers every time, or we're able to get people medication sooner. So even if they do have to go to the hospital, their length of stays are shortened. um, their quality of life is improved because they're not spending so much time, which directly correlates to the economy, right? Because people who are not productive members of society, because they're constantly in and out of the hospital, are not just beating up the hospital, but they're not contributing. They're not doing a job. They're not spending money. They're not making money. They're not doing anything. And they become a burden on society.
right.
Um, and in the sphere of EMS, we have the ability to kind of change that right at the first meeting.
Um, I feel like it would boil down to a lot of like how I look at it is like, would it be more beneficial to, let me backtrack. So it's not so much the requirement that an EMS provider needs a degree, more or less, but also you could tack it on that having a degree would help the overall provider, but also, I mean, as an easier route, more or less, like changing the actual like paramedic programs, EMT programs, stuff like that to like before you even have to, or you should go get your degree, like we can, I don't know how to use the analogy, but like get the program, cut out the stuff that doesn't even needed, not like any part of the program, but like just the extra stuff of like, hey, we don't really need to focus on that so much. We need to focus on this, and like kind of buffing it out and shaving away certain parts to make it more like add in more pharmacology and take away so much of the operations and safety management, add in more education about site calls, and take away the idea that like you have to know, I don't know,
No,
like,
I get what you're saying. That makes
yeah.
it's a fair argument, because right now, what from what I'm hearing is and I agree with you. Like, the most awful part of EMT school and paramedic school was operations. That shit just bored the shit out of me. Like, no, none of that was like learning the different style ambulances. Really? Like
Stupid.
what the
So
and
stupid.
if somebody that listens to this show can tell me why that's helpful or useful, I would love to know. But it is. It's a stupid and stupid is probably a strong word, but you said it, so I'm saying it too. The it's it just seemed like fluff. It just seemed like stuff that they were like, we don't have a whole uh, uh day of training, so let's just throw in what style ambulances there are. And let's throw in some operational stuff that 99% of you aren't even going to use ever. And when you do use it 10 years from now, you're going to have to take a NIMS course anyway to learn about operational
Right.
seizure, right? So yes, I agree with you. I think there are a lot of things that are in the programs currently that are silly. And you're 100% correct that pharmacology could be better, could be could be more in depth. Um, and yeah, I mean, we could definitely do better with mental health. Like it's just that's a big issue in EMS. I think we see a lot of psych patients with
Yeah.
mental health issues and psychological and psychiatric issues, but we are not very well prepared to deal with those patients. And again, it's one of those things where if you remove mental health, like you're not remove, but if you attack mental health from a different, standpoint, you start teaching people, do those people actually need to be hospitalized or jailed? Probably not. Medicated, and lots of them need to be, in group homes and in places that keep them safe and keep, society safe. But yeah, EMS I've never been very good at dealing with psych patients because my um, level or my ability to deal with that kind of um, just the incessant arguing and arguing for very zero reason. They're just, I get angry and I'm like, you know what? Fuck this person. I'm out of here. Like, I'm not going to deal with that. Like, why should I deal with that? I'm not doing anybody any justice. But yes, we should definitely have more training. So are you saying we shouldn't have a degree and we should just have lots of training? Or are you saying that the degree programs need to remove some of the shit from them?
Not necessarily that we don't need degrees, but more of, if we're going to start somewhere, not so much a push for an associate, but like we just like cleaning up how we're training our future providers, and even like during those programs instilling the need of like, hey, just because school is done, it doesn't mean you are. Like, instead of this big push of what a lot of programs have, is like, oh, take our program because we have a 92% pass rate, but you're
Right.
going through it and like, bro, I'm drowning, and not just drowning, but like, I don't want to do this anymore. I just want to pass registry and get out in the field. Like, I'm done with school.
Right.
But yeah, I
So let me ask you this. Just think about this. You don't have to answer it, but so education, it typically requires a master's level or PhD level, like degree. Who builds college programs? It's those people. And so in order to have an EMS degree that's very EMS focused, because that's who we're sending out to the field, we're going to be sending out paramedics that are degree trained to the field. Someone designs those programs, and those are those PhDs and those master's level providers that are going to be sitting at those tables. Because right now, it's probably somebody that's a doctor that works at the college that's designing these programs with some master of education lady that's just throwing whatever they see that the nursing program has or the RT program has and go, you know what? Let's put that in there too. Let's just do that, even though it doesn't have any relevance to our our part of the industry or our part of the of healthcare. Um, so yeah, uh, the programs currently, there's no standard. And so I think maybe, there's three levels of importance here. I think we need to be an essential service nationally, right? First, so that EMS is considered essential, just like every single other one. That way, it's paid for and it's taken care of, and people get the care. I think the next step, uh, I was going to say education, but I maybe let me think. So, so you have you, so after that you need standardization. We need a national standard of what paramedics are doing in EMS, right? Right now there's not there's it's so fragmented. I mean, you can go to an associate's degree in Virginia and get your paramedic, and you can walk to the street and do the same care that somebody from backwoods program went to. Um, and they could both be great or one could be bad, but when they walk into the home, it's just like we started at the beginning. The first thing they see is that you're a paramedic. They don't give a fuck where you went to school. They want
Mm.
you to be qualified and capable and competent at providing the care for their family member or for them. So standardization, and then you know education, and looking at degrees. um, but I think once you standardize and once you get buy-in from governments, local governments, and you start to standardize, then it's easier to design programs focused on educating at the bachelor's level, or even better associate's degrees, because maybe it is just an associate's degree that we need. I don't know.
So,
I don't have a bachelor's degree in here.
I'm really glad you said that. My last little caveat was, if so, say we push our providers to get degrees and stuff like that, and maybe not so much like the just a degree in something. I mean, I think it's smart to have like a backup plan, like a fallback plan, because I think y'all talked about, like, I throw my back out, I can't work anymore. And if thankfully I have an English degree, but if I didn't have that, like, what am I going to do? If, our providers who right out of high school got their EMT and now they've been a paramedic for so many years, like, what's their fallback? And I know there are different jobs and stuff, but like, as far as experience required, but so with the degree and kind of like that standardization, is it a thing where like you get your degree and you've arrived, or are we still going to require the recert, not just through national registry, but like ACLS, PALS, PHLS? Is it like a one shot done, or are we still recerting?
Yeah. I do think there's a need for a recertification, um, because it's there's not necessarily a way to ensure that competencies are being met other than by I I don't know of any, because just because you have a degree doesn't mean that you're maintaining those proficient or those competencies. So I do think that there's a need. I would argue in favor of an annual uh research, but that's because I like to push. I don't think I would like to have to research annually,
Mm-mm.
but I also think that researching annually we keep people focused on trainings because they have to do these trainings. But is it necessary? I don't 100% know. But what was the second part of the question?
It was
I,
mainly like, if you get a degree, like, are you done or do you have to
oh,
recert? I mean, yeah, that was pretty much it.
yeah. So the no, I don't think ACLS and PALS and any AMT or AHA courses required that. Because if you're doing them and you're doing competencies through the recertification process, why in the fuck do you need to go through an ACLS course? If everything is standardized, I'm just going to use that loosely,
Yeah.
then we would be getting that training like we should annually or biannually. I am not a fan of the NAMT. You probably already know that. Not a
I've
fan
noticed.
of, yeah. I'm not a fan of the I'm not a fan of the AHA's canned courses. I just don't think I don't think there's a lot of value in them. They're great for people that don't know shit. They're useful. But
They're
they
great on
make
paper.
sure, they make us worse providers because we're trying to use all this knowledge that we have in our brains from experience, and now we're told we can only do XYZ because that's what we're doing is following ACLS. So no, I would say, but that ED docs, critical care docs, don't have to take ACLS. They're not required. It's only nurses and medics, and docs who are not working around it frequently. I think we work around it enough that why do we need to learn what the AHA considers quality treatment? And the evidence is the same everywhere. That's just a great place that they put it. The problem is it's so far behind. Um, and it doesn't take into consideration advanced providers, right? It doesn't take into consideration a medic who's got 20 years, and let's say they have a master's degree in EMS. I'm just like it doesn't exist, but you know what I mean. They have a master's degree in this EMS thing, and these are master clinicians that are basically PAs. Do you really want to, handcuff them by saying you got to follow ACLS protocols? No, you want them to do what's best for the patient. And if what's best for the patient isn't what the ACLS says that, specifically, then you're just making care not as good. But it goes back to that whole, do they trust us? So no, they don't. They give us rigid, stringent guidelines to follow because no one can say that you did something bad if you followed ACLS protocol or ACLS algorithm. I followed the algorithm. So you can't blame me. They died. You know what I mean? So,
Right.
I mean, it's true, right? Like, as long as you follow the protocols, no one, there's not a real expectation for you to think critically. There's just like, okay, you did what you were supposed to do. I know that there are some protocol books out there that says this is like not a substitute for critical, that basically you should use critical thinking,
Hmm.
but not a lot of people know that. Not a lot of people see it. And a lot of people just want to fall back on ACLS. Because it's safe, it's comfortable, and it protects hospitals and departments. This is just a good way to protect money, and the AHA gets to make fucking what $40 per card or $30. I don't know what they make, but
Yeah.
same with the AMT. Like, really, seriously, do we really think that these courses are really helpful? Any of the shit that you take with them is not something that you could have learned from a good educator, like somebody who was actually trying to teach you something. I just don't see a lot of benefit in any of those courses. I've taken all of them,
Well, not
but I
just
think
that,
they're
but
all
like, so you have your ACLS, you go over your rhythms, you go over the algorithms, all that stuff. At the end of the day, you also have your protocols written by your medical director that at one agency, they tell you outright, like, if you don't work under your protocol and you go rogue, wild, wild
deviating.
west, like you're on your own. So, and one little thing, and I don't want to go on a tangent, but as far as standardization, tell me why I worked at one agency here in Louisiana and anaphylaxis and asthma, whatever, was one dose of epi versus I go out of state to another state and the epi dosage was different. So, like, not even just standardization of how we're pushing out these providers, but like, bro, why?
Who
I
was
don't
right?
know. Yeah, exactly. So, like, even in protocols, like if,
Yeah, because
ACLS
it's
or,
physician based, right? The physician makes a determination on what the protocol is, right?
yeah,
Yeah. So the medic doesn't get to sit in the room and say something like, I don't know, like, I've worked for fucking 10 departments and everybody's doing this dose of epi. Why are you doing this dose? Because that's what the literature supports. Okay, well, show me that. Can you? And you have the ability to read literature, research now, and not that you have to have a degree to read research, but you've learned it. So you can read the research and you can analyze it and you can better understand why they decided to do that. Uh, but yeah, I mean, what was the dose that somebody else used
In
for
Louisiana, it was,
anaphylactic?
yeah, and Louisiana was 0.3, 1 to 1 epi.
Yeah.
In the other state was 0.5 milligrams of epi 1 to 1. Like, kudos to the aggressive treatment, but like, bro, I don't know. It just felt like
You're,
a lot for me.
yeah, but I'm not saying that either one of them was right or wrong. I
Right.
agree with you on the first one, but sometimes I wonder if the person that wrote that aggressive protocol was the one who was actually not templating protocol from another protocol. You know what I mean? Like, so maybe the proto again, this is just a theory, but like maybe the guy in North Carolina, sorry, they're both hillbillies to me. No offense to you. Redneck hillbillies, there's all the same. The Jason's from North Carolina. Uh I started EMS in North Carolina. But I wonder, like, so was your Louisiana protocol just somebody who was like, this is what they're using, so that's what we'll use. And that's what they use, so that's what we'll use. And maybe the point five was right. I don't know. I I do agree though that it's very hodgepodge and things are kind of, you know, pieced together not very well. And because you work on the street and you'll open up your protocol book occasionally to kind of get an idea of what you're supposed to be
Yeah.
guided, and you're like, whoa, this doesn't make any damn sense. How am I supposed to get to A or to B from A when A is really, it's just like the way that they're written and the way, I don't know. I like protocols because they are protective.
It's a safety
So
net.
it
I
is a
will,
safety net. It's also a good guide, right? For care
yeah.
that you don't do all the time. Like it does help me, or they did help me a lot when I was newer and I was trying to, be sure that I was doing dosages correctly. So for like medications, I typically opened it up.
Yeah.
Uh, fentanyl is 50 mics or 100 mics. So you don't have to open up your protocol book every single time. But if it was a kid, I might open it up and be like, okay, let me make sure I'm doing this correctly.
Yeah.
So protocols do have a place. Will protocols always exist even when we have degrees? Yeah. I mean, SOPs are important. It's standard operating policy so that there's a baseline for lawyers because we always have lawyers in society. So until we don't have lawyers, we have to have protocols.
I will say I do have a teeny little notebook I keep in one of my pockets every shift where it's like our medications that we carry. Like each page is one of our medications and it's like the dosage and the protocol of why. Also, our protocols are beautifully displayed. But also I'm just kind of dumb. So like if we're going to
I
a
think that's
specific
smart.
call, well, I just forget. And I don't want to be on like for instance, we had a 1-year-old status epilepticus wouldn't stop seizing. Before we even got there, like I got those notes, I quickly wrote out like our dosage for pediatrics, like the verse said. So that way I don't want to be looking at this kid seizing, trying to flip through a chart and figure out like, man, I wonder how much Versed I'm supposed to give them. I don't
So
know.
you know what you just told me? You are preparing to be a flight paramedic.
Mm-mm.
Yeah, that's what you just told me. You know why? Because that is legitimate. Ask any flight medic on their way to the scene or do a facility transport. They are writing down all of that information on a piece of tape on their leg or on a piece of paper that they have handy. So you get the, let's say you get just, we'll just use a scene because a scene seems to be more what people like. And let's say you get a scene flight and it's during the day, so you don't have to worry about all that other shit. But let's say it's during the day and you're with a nurse and you go out there and en route to the scene, let's say it's 15-minute flight from your base to the scene, you're getting as much information as possible from your dispatch, but also from the scene. And so the information that you're getting is the type of patient. Is it a man, a woman, a baby, a boy, a girl, how small, the weight, what's going on, and shit like that. And what I would do, because you're right, in the heat of the moment, it's really hard to do med math, right? Because you're trying to you want to just give the med. You don't want to have to fuck around and be like, ah, I don't know what the dose is. So you write it down on a piece of paper or on a big old piece of tape people put on their legs. And so that way, when you get there, you look at the patient, you know how much the patient weighs, you can administer the medication. And I would do it for every medication that I could potentially think of using. So even if I wasn't going to RSI the patient, I was still putting those dosages down because if it came to the point where I was going to have to RSI or we were getting bad information, I was already prepared.
Yeah.
And I think that's an intelligent way to be, especially if you know that you don't do well with math under high stake situations, which I don't. I have to have a reference. Unless
It's why I
somebody,
got an English degree, because math is not my friend.
no, I mean, and we don't do a lot of math, but the math that we do is critical math.
Mhm.
Uh, Fortunately, we have a lot of products out there like hand tabby that can kind of help people, but you got to pay for it and you got to be trained on it. Broslo works really good, but Broslos just aren't very useful when you're on a scene and you're trying to intubate a 4-year-old patient who's got a head injury. It's just not the time that I want to be trying to dick around with something. I just want the information right there. Yeah, I'm going to confirm that this patient is 30 kilograms, but I don't want to have to look through these colors and try to, oh my God, it's just it's not a fun place to be,
No,
period. So good on you for writing it down.
no,
I like that.
it's
Strong work.
whatever. Oh,
Strong work.
thanks. Um, I don't know. A lot of good points, a lot of just good discussion. I feel like one last thing about sitting at the table, I would hope no matter what agency you work at, you have at least a decent relationship with your medical provider or your medical director.
Yeah.
I worked at a system in Utah that we didn't carry, I don't know if they do now, but we didn't carry Atrovent. So I went and we didn't carry Solumedrol. So I had a sit down conversation with them. And I'm like, hey, doc, mad respect to you, but can you please explain? And it turned out that like years prior, these medics were given like these duonebs and then an additional duoneb instead of just albuterol. And then an additional. So I was like, cool. We don't do that. So like, can we please? And I'm not gonna lie, it took me dropping off a patient, severe asthmatic, and the ER doc was like, well, why did you only give albuterol? And I'm like, we don't carry Atrovent. You can tell your colleague, Dr. So and so. And then Solumedrol, like kind of that aspect of sitting at the table. Cause he was like, well, our transports max are like 15 minutes to get to our hospital from where you guys pick up. I was like, cool. But also, doctor, all due respect, if you calculate our time from patient contact to
Mhm.
getting our vitals to getting our treatment, and then or when we transport, when we get to the hospital, when we do our patient handoff, you assess them, you start getting like your orders and stuff like that. I was like, bro, our Solumedrol is already running. And if
Yeah.
you don't like it, the half-life is incredible. So I don't know. I feel like having that mutual respect, even if it's not global or like nationwide, whatever, if nothing else, having that ability to sit down with your medical director and have those conversations and have that respect because you're not dumb and you actually care, which plays into all of this. But
Sure.
I feel,
100%. Yeah.
yeah,
No, I don't disagree with you. I am a proponent 4 degrees for all the reasons I've stated. Could a person without a degree do all of these things? Oh, yeah, absolutely. That's just not the way that we are, right? Most people are not going to take the initiative. The Atrovent's not in the protocol. Patients don't get Atrovent. And that's the majority of the people. Solumedrol's not in there. I didn't want to draw it up anyways. It's a pain in the ass, like I don't want to have to give that. Why do I got to give it? It's not going to do anything for me right now anyway. So why should I give it? You went in there with knowledge that maybe nobody did have. You were bringing something to the table. Um, so kudos for that. I think that takes a different kind of person. We have to look at EMS as not you and me. You have to look at it
Yeah.
as the people that are not doing those things. And so, you said it at the beginning, we have to figure out a way to either raise the bar or filter people out
Yeah.
in order to provide better outcomes. Because at the end of the day, realistically, the goal of EMS is to provide better patient outcomes. It really is to help people. We know that Solumedrol decreases length of stays
Yeah.
and it decreases ICU stays. So it is beneficial not only to the patient, to the hospital, but it's also beneficial to the economy.
Oh, bro, I had a whole PowerPoint on Atrovent and Solumedrol. I literally I spent a hot minute looking up all this stuff, and I was like, "Hey, doc, even if you don't like Solumedrol, hey, look at dexamethasone." So I, I was
Yeah,
ready. I was fully ready.
I wish they
Um,
would do dexamethasone, but
I love it, but that's just me.
the Army doc had something recently. He's talking about it. Got to follow him.
Smart man,
I plugged him.
but
I don't know. I don't think he likes the idea of paramedics being their own medical directors, but that's for a different argument. And
right.
but yeah. I mean, you know, at the end of the day, physicians are going to be a part of our thing. We're never going to have a wheelhouse where we just operate in our own little silo
No.
ever. But when we do operate it in, with everyone else, we need to be able to articulate a need or a desire or be able to explain things in such a way that it elicits a response that's beneficial to patients and to us as providers. And I just don't see a lot of that right now. I mean, I work at the hospital, and it's the hospital that is the same agency I work for as a medic. I mean, they walk in there, and I cringe. They
Mhm.
look like just. I know you said it like it doesn't really realistically correct. It doesn't really matter if you have a shitty uniform. Not if you're a great medic and you have a shitty uniform, like you're still providing great care. But come on, dude. Like
Yeah.
you look like trash. The physician sees it, the people at the house see it, the nurses see it, fucking 7-Eleven sees it. Uh, everybody that you walk into is like, that's the dude that's taking care of me. No thanks.
Dude,
I'll
we've
drive
had
myself.
me and my partner, like we look nice, whatever. But we've had patients that like we show up, and I'm gonna be honest, we're private and both, so it's transfers, and they're like, "You ladies look so much nicer than the last crew that picked me up," and I'm like, "It shouldn't be like that."
To not be like that. And standards and raising the bar. Until we raise the bar, yeah, it's going to be it's going to be like this for a while, I think. I feel like my life as a paramedic in this realm of whatever it is that I'm doing, some narrative agenda I'm never going to have to stop arguing for better standards. Like I'll probably be dead before they're raised. Do I want that? No. But I just have a feeling that I'm going to be pushing the same
Yeah.
points out every year until, I mean, maybe the degree thing will happen, but then I can find other things to bitch and complain about.
Look, worst case, we put on your tombstone, he tried.
Yeah, I'm a good trier. I'm a great trier. I'm always trying. But no, so I need to get going, but because
Yeah,
I
dude,
my
I
mom.
was wrapping it up. You're good. Yeah, tell your
Oh,
mom
good.
happy birthday.
I will. She's old, but I'm gonna tell her you said happy birthday. I got her a present. So
Cute.
we had a t-shirt. We had a t-shirt framed. I wore this t-shirt when I was a kid that said Betsy's home for wayward boys. So my mom's name is Betsy, and I was one of the wayward boys. I found it in a box. So it's like this little shirt when I was like 3 years old or 4 years old. We had it framed, and so we're taking it over there to give to her.
That's precious.
Yeah, we'll see if she likes. She'll probably say it's nice and then put it in the trash.
Oh,
But
well,
I wanted to say thank you for reaching out and asking me to come on. I do wish Jason could have been here because he has a little bit of different perspective on this stuff than I do. But as we said in the beginning, he's busy with life, or what his
fair.
opinions are. But no,
Yeah.
it's good to be able to come on to a different show and talk instead of being the talker.
No, I appreciate it, man. It really,
Yeah.
I've been stoked about this, man.
Me too. Probably
So
more than you think. I don't get to go on podcasts very often. I don't think of my own show as a podcast. I think of more of it like a duty. So it's nice to be able to come on somebody else's platform. We'll see too. Maybe our collaboration will help us gain more followers and disseminate this information a little bit farther.
I am always all for discussion and riling people up the best I can. So, but yeah,
Yeah, me
dude.
too.
Yeah, if you ever want to come back on, just hit me up. I'm always looking for people and slash or trying to find different topics to talk about. So I'm here for
Yeah,
it.
I got you. We're always around, so you always just message me. I'm happy to come back on. I'm also going to look to see if I can find any of those guys from Australia that you could have on.
Thank you.
Yeah, I'll let you know. I'll tell you two people offline when not today, but another time
Yeah.
not to have.
Okay, thank you.
Yeah, I got you. I've had them on. It was a terrible experience. Yeah,
I appreciate
but
that.
whoever it was said that we stole their logo because it was an ambulance. I was like,
Oh my God.
they're arguing like, you have an ambulance and I have an ambulance, and it says ambulance on the front. And I said, okay, you realize that that's the entire field. Like
Yeah.
everybody's gonna have an ambulance incorporated into them somehow. All right, you came up with it. All right. Well, thank you again.
Thank you, Aaron. I appreciate you.
Yeah, we'll maybe we'll have you on the show, and you can have us. You can ask us questions, and or I can ask you questions.
I'm down for it. Kind of scary, but down for it.
One day.
Yeah,
All
man.
right.
Go enjoy your
Well,
mom's birthday.
thank you, and thanks again.
Yeah, no problem.
Bye.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.